Hi, this is Brenda. The topic of this mini module is the infection group B Streptococus. You may also hear it referred to as GBS or group B strep. In the 1970s, GBS emerged as the leading cause of neonatal sepsis. It is a gram-positive beta hemolytic cocci that likes to live in the GI tract. And as you know from women's anatomy, that provides easy access to the vagina. It's estimated that 10 to 30% of women are colonized, and it's possible that all women are colonized at some point in their lives. African American women are twice as likely to have GBS than white women. Young women in Hispanic populations are also more frequently colonized. In women, GBS infection is usually asymptomatic. It may be chronic, intermittent, or transient. Transmission to the newborn can occur through ascension of the infection from the vagina, which is vertical transmission, or horizontally, which is cross-contamination, usually due to poor hand washing. How heavily colonized the woman is, the site of colonization, and if it's a chronic condition, can all affect the transmission rate. Risk factors such as preterm status, prolonged ruptured membranes, or other medical conditions also influence the transmission rate. Despite significant improvements in the identification, treatment, and prevention since 1990, GBS still remains the leading cause of early neonatal sepsis in the U.S. In the early 1990s, there were approximately 1.7 cases of neonatal GBS infection per 1,000 live births. Since then, recent statistics show there are now approximately 0.5 cases per 1,000 live births. So as you can see, the rate of infection has decreased, but it's still more than it should be. In 2002, the CDC developed guidelines for universal screening. All women between 35 to 37 weeks will have a vaginal rectal culture done. 95% of these cultures will remain negative for 5 weeks, and that is why this particular gestational age was chosen for screening. There is approximately a 5% false negative rate. There are a couple of exceptions to this universal screening. In these cases, the risk of transmission to the newborn is very high, so these women will receive antibiotics prophylactically in labor. GBS in the urine indicates the woman most likely has high colony counts. Two things will occur with these women. The GBS urinary tract infection will be treated at the time it is identified. Then the woman will receive antibiotics in labor to help prevent transmission to the newborn. A woman who has had a newborn previously who was affected by GBS sepsis does not need the culture, but will instead receive antibiotics in labor. The universal screening is completed by doing a vaginal rectal culture. The swab is inserted into the vagina, the outer third of it, then swiped down the perineum and inserted into the rectum just past the anal sphincter. It's not recommended to use a speculum or to do cervical cultures. With adequate education, the patient can perform the cultures themselves, and oftentimes they are more comfortable doing it than having somebody else do it for them. To ensure the correct antibiotics are used to prophylactically treat a positive culture, susceptibility testing should be completed on the culture for any woman who has an allergy to penicillin. Treatment is recommended for any woman with a positive vaginal rectal culture that was done at 35 to 37 weeks. Remember, the risk of transmission is very high for women with a history of GBS bacteria at any time in this pregnancy, or if there's a previous history of a newborn who was affected by GBS disease. So these women will not have had the universal screening, but instead will get antibiotics prophylactically in labor. If she hasn't had testing done, or if you don't know the results, treatment is recommended in the following cases: a gestational age less than 37 weeks, or ruptured membranes for 18 hours or greater. These are risk factors for the newborn developing an infection. If she develops a fever in labor of greater than 100.4, this is an indicator of infection, and the most likely organism causing this infection is GBS. Treatment is aimed at prevention of early onset neonatal sepsis, which is different than treating a sick newborn. It started once the decision to admit the woman to labor and delivery is made, and continued until the baby is delivered. For C-section patients, they should have the universal screening done at 35 to 37 weeks, and then if it's positive, antibiotics are only given if they come in labor or with ruptured membranes prior to their scheduled C-section. Because the risk of transmission is very low, no treatment is needed if they are not in labor and their bag of waters is intact at the time of their C-section. In 2010, the CDC came up with treatment guidelines for prophylactic treatment of group beta strep. The recommended agent is penicillin G because it is a narrow-spectrum agent. The initial dose is 5 to 6 million units IV piggyback, and then 2.5 to 3 million units are given every 4 hours until the baby is delivered. You may also see ampicillin given, but penicillin really is the better choice. So how do we know that the treatment we're giving is adequate to prevent neonatal infection? The American Academy of Pediatrics has defined adequate treatment to be at least 4 hours after the initial dose of penicillin G, ampicillin, or cefazolin was given, and the delivery of the baby. These antibiotics are given every 4 hours, so some nurses and physicians mistakenly believe this to mean the patient needs at least 2 doses of these antibiotics to adequately prevent GBS transmission. If a woman is allergic to penicillin, susceptibility testing should be performed on the GBS culture to ensure the correct antibiotic is used. A good history concerning the woman's allergic reaction is also very important, as some individuals will often report an allergic reaction because they experienced a common side effect, like nausea or vomiting, or because there is a family history of an allergy to a particular medication. When there is a true allergy to penicillin, there are 3 antibiotics that are approved for GBS prophylaxis. Cefazolin is used when there is a low risk for an anaphylactic reaction to penicillin. Approximately 20% of GBS isolates are resistant to clindamycin, so that antibiotic should only be used when there is a high risk for anaphylaxis and the GBS is sensitive to it. Vancomycin is used in women with a high risk for anaphylaxis, and sensitivity testing shows a resistance to clindamycin, or there's no sensitivity testing done and there's a high risk for anaphylaxis. Neonates affected by GBS sepsis can have long-term neurologic complications, and they can die. This is why we try to prevent transmission and treat with antibiotics in labor. There are 2 types of neonatal sepsis. Early onset occurs in the first 7 days of life. The first and most common symptoms are temperature instability. This is where the newborn cannot keep their temperature in the normal range. They may also exhibit hypothermia, poor feeding, and lethargy. Newborns are not likely to be febrile or hyperthermic. Respiratory distress, pneumonia, apnea, and shock are also symptoms of early onset neonatal sepsis. Late onset sepsis occurs from 7 days to 3 months and often results in meningitis. Nursing responsibilities include reviewing the record of all patients admitted in labor for their GBS status. This will include the vaginal rectal culture results done at 35 to 37 weeks, any history of a GBS urinary infection at any time in this pregnancy, and pertinent past history of delivering a newborn who developed GBS sepsis. Providing prophylactic antibiotics to those who need it, and then communicating the information to those caring for the newborn, including the pertinent history, treatment given, number of doses, as well as the length of time that has elapsed since the first dose. And for those caring for the newborn, the primary nursing responsibility is to monitor for signs and symptoms of neonatal infection. Prophylactic antibiotic treatment is able to prevent the majority of neonatal GBS sepsis cases, but not all. If a mother did not receive an adequate prophylactic treatment, her newborn is at greater risk and is given IV antibiotics only if they exhibit signs and symptoms of infection.